another Piper Pod. Today we're going to start looking at things that statistically we see a hell of a lot more of. Okay, and that's starting what I hope to be is a large series of patient examination where we'll take common disorders, common injuries, and we'll break them down to aid in your knowledge of these actual disorders, what questions to ask, what investigations to do, and how to best manage those particular disorders. So to start it off, we're going to start with an extremely common disorder, and that's diarrhea. Okay, so diarrhea in itself can be a diagnosis, but it's often a symptom of a different disorder. Now, if you look up causes of diarrhea, there's numerous. There's probably 100 different causes of diarrhea when you break it right down. But today we're going to break down exactly what it is, what pathophysiology occurs most of the time in order for diarrhea to start, and then what you can do about it, what sort of things you should look out for, what sort of red flags there are, and how to best manage diarrhea itself. Okay, so diarrhea is a global problem, okay, resulting in over 15 million deaths per year, most of those being children. Around 11 million deaths a year occur from diarrhea of children. Okay, so it's a very, very large scale problem. Now, when you see a patient with diarrhea, it can be very acute and benign. Okay? It can have absolutely no follow-up, no real treatment needed one day, and then the next patient, it can be catastrophic, where they need massive recovery and long-term treatment in order to treat their diarrhea. So because it's so vast and so complex in a lot of ways, what I hope to do today is shed light to the major issues, what's actually occurring within the body and how we can identify it and treat it best in the environments that we work with. When you're dealing with anything within the digestive system, you have to remember that you're not dealing with one thing at a time. So if a patient were to come to you with a complaint of diarrhea, we can't just focus purely on the large intestine or the small intestine or their diet. Okay, we have to think about the digestive system as a whole and the actual person as a whole, because there's many factors that can contribute to diarrhea, and the digestive process is assisted by ancillary organs. Okay, so whether it's salivary glands, the mechanics of chewing, the actual liver enzymes, the gallbladder bile production, the pancreatic juices, they all play a very, very key role in the person's digestion. Okay, and any form of mix-up, if you will, or malfunctioning of any one of these organs or any one of these processes can result in a side effect being diarrhea. Okay, so we'll talk more about the ancillary side of the house and how each one of those can help us give clues to how bad diarrhea is. But just remember that when you're doing an examination, especially on digestive problems, we need to broaden our focus. Okay, we cannot get fixated on the one complaint. Okay, looking at the main areas of the digestive system, stomach, small intestine, large intestine. The reason I say main areas is because it takes up the most physical mass of the digestive system. In front of you, you can see the histology of each one of these areas. Okay, now note that they're vastly different, okay, because they all have very special roles. So I'm just going to talk about each of them for a little while because it will help in your understanding later on of how diarrhea occurs and what things to look for to help diagnose particular areas. Okay, so starting at the stomach, even though the stomach's it's not the cause of diarrhea, obviously. If you have a stomach specific problem, it's not necessarily diarrhea, but I use it as a comparison. So the linings of the stomach wall are coated in a thick bicarbonate layer in order to protect it from the acids. Okay, it has pits within it. So if it was the absence of that high bicarbonate layer, it would have the same absorption capacity as the large intestine. But that's not its role. Okay, the stomach's role is to aid in the breakdown of large molecules into smaller molecules. Okay, it doesn't do absorption. The problems associated with the stomach are usually associated with a mixed mash in pH, so 2 acid, 2 alkaline, and a breakdown of this bicarbonate layer. That's the main concern. The stomach itself doesn't absorb much, okay, outside of alcohol and acetylic acid. The stomach role is not to absorb nutrients. It's to break them down to a smaller role before it pushes it onto the small intestine. Now the small intestine, you'll see, has extremely large villi right through it. Now they're not always large right through it, but at the start of the small intestine they're quite large to aid in motility and also to increase absorption rate of the nutrients. Okay, so it has specialized structures and specialized cells, usually one cell thick epithelials, to aid in the absorption of nutrients and ions. Okay, so it's full of ion channels, it's full of specialized cells that help in the mediation of digestion, okay, like your inflammatory mediators. Okay, it has a close link to your immune system. You'll often find pilus patch nodes from the lymphatic system throughout the small intestine because it has the ability to signal macrophages, T cells, that sort of thing, in order to communicate with the immune system as required. The main role of the small intestine is absorption of nutrients and ions. Special structures about the small intestine is it's not very flexible. Okay, the small intestine cannot grow with ease, and any growing or enlargement of the small intestine is often associated with pain. It also doesn't have a large amount of bacterial flora found within the small intestine by design, because it's designed for absorption of already digested thing and further digestion of particles. It really doesn't need a lot of bacterial flora within it. Unlike the large intestine, which as you can see has very small villi, if any at all, has a very similar structure to the stomach, because it's responsible for, like the stomach, the release of digestive hormones like your serotonin, histamine and gastrin. Okay, they're released from the actual pits within the large intestine, and the absorption of water is the main role of the large intestine. So once all the nutrients and everything has been absorbed, you're left with waste material and water. Okay, so the medium which allows the small intestine to travel gets to the large intestine, and then the absorption of water occurs. The large intestine is extremely flexible. It can stretch with ease and generally without pain as well. And when we're dealing with constipation or impaction, the patient won't actually complain of the stretching of the large intestine as a discomfort. It's usually the stretching of the rectum or the associated bacteria moving into the small intestine that causes the pain. The large intestine, as opposed to the stomach, does not have a thick bicarbonate layer protecting it. Therefore, it is able to absorb the fluid. Now, fluid mostly will travel in between the epithelial cells into the interstitial space before it moves into the intravascular space. Okay? The cellular structure also contains ion channels, but not as many as the actual small intestine. Okay? Not as specialized as the small intestine itself. The large intestine is riddled with bacterial flora, which aid in the further breakdown of food products and also in the production of vitamins like vitamin K, aids in our clotting cascade, also comes from the large intestine itself. Now the large intestine is very talented at absorbing fluid. Okay, it's been written that it can absorb 7 times the amount of fluid that the actual body needs through the large intestine. The problem is that it takes time. Okay, so if you ever hear the anecdote of hydrating someone rectally as a good idea, whilst the large intestine is effective at absorbing fluid, it takes a significant period of time in order for it to do that. Now when you have a case of diarrhea, normal stools consist of 75% water, and it only takes a consistency of around 85% water before it's considered to be diarrhea. So we're not dealing with huge difference in water concentration, and it can just mean that slight reduction in absorption of fluids or reversal of osmolarity that happens within the body that can cause someone to have diarrhea. To break down the actual causes of diarrhea, whilst I alluded to there being many causes, over 100 I said, those hundreds can be broken down into 5 main causes. Okay? Now when we're dealing with the ingestion of poorly absorbable material, it essentially means that non-absorbable matter that is found within your intestine is going to alter the osmolarity. So when we alter the osmolarity of an area, it is going to draw fluids into it. So if there's something that your body cannot absorb that you have ingested, then that is going to result in a reversal of the ideal osmolarity, and that is going to draw fluids in to the body. So diarrhea can often be described as being caused by osmolarity mixed mass, inflammatory or secretory problems. Okay, so the first one is in the category of an osmolarity problem. When we go down and we look at the second one, now this is by far the number one cause of diarrhea, different reasons. This is when the mucosal intercellular epithelials are stimulated to release enzymes. Okay, now enzyme is your cytokines. Now, two different things occur. Now, they either occur together or independently of one another, and that's what makes the difference between inflammatory or excretory problem. Okay, so when the cytokines is released, it can trigger macrophages within the actual small intestine to start breaking down your pathogens. Okay, and then you'll get external macrophages moving in that will essentially bust through the wall of the small intestine in order to assist in this roundup of pathogens or toxins. Now, it's that infiltration of macrophages that releases your inflammatory responses, like your prostaglandin, your adenosine, okay? And it's that inflammatory responses that will cause essentially the malabsorption of nutrients and fluids within the bowel. Okay, so this in itself is saying this is your true inflammation of your actual digestive tract. So when you have your enditis, as it's known, this is what the causative agent is. So it's mostly caused by pathogens, your viruses, bacterial protozoas, or toxins that you've induced, or toxins that they produce that cause this problem. Okay, so that is your number one causative agent of it. Because the same thing occurs in the absence of your macrophages, just with inflammatory responses, when you're dealing with things that your body's intolerant to. So someone who is lactose intolerant eats lactose. It is that lactose that is going to cause the inflammatory response, okay, bypassing the macrophage aspect, but still having the same result of inflammation and malabsorption of the actual nutrients. Now, sometimes when the macrophages come in and they start destroying things, if the pathogen or toxin is embedded within the epithelial cell or the enterocyte itself, so the actual cells within the digestive system, then it's the macrophages and the associated lysomes that can destroy the integrity of the intestine. So when the integrity of the intestine is destroyed through that reason or other ways, it also results in a malabsorption. If you can't absorb any of the nutrients or any of the ions, you also do not absorb the fluid within the small intestine. If this problem is in the large intestine, then you have a direct no absorption of fluid itself, which results in the diarrhea. Okay? So depending where it occurs, you can have associated just hydration problem, so a lack of absorption of fluid if we're dealing with the large intestine, plus or minus the inability to absorb nutrients if it's small intestine. Now, the fourth one, which is increased intestinal motility, is generally associated with the actual pathogen or the stimulation of the enzyme itself. That increases peristaltic motility. Now, it can happen independently, but it's often as a result of something else. So if we increase gastric motility, therefore the fecal matter is spending less time in the large intestine. As I mentioned before, it's the large intestine that absorbs all the fluids, but that takes time. So if the feces are not in the large intestine long enough, it will not absorb the fluid, therefore you'll have a large volume of fluid being passed. And the last one, luckily we don't see very often, this is your cancerous type problems, okay, or any form of obstruction within the lymphatic or vascular system surrounding the digestive tract. You are going to have an increase within the hydrostatic pressure of the lymphatic or venous system, which is going to push fluid into the digestive system, okay, because it's going to build up with a backload of fluid next to the digestive tract, that pressure, hydrostatic pressure, is going to grow, and it's going to push through the actual semi-permeable membrane or in between the cells itself into the digestive system, which in itself is quite a negative space. Okay? And that obviously increase in fluid introduction is going to result in diarrhea itself. So there's your 5 main causes of diarrhea. Now, some of those obviously have a large gradient of problems. Okay, so each one of those, minus the last one, can be minor or can be quite profound in themselves. So just knowing the causes and how to break down what causes diarrhea is not necessarily going to help us, because we need a little bit more knowledge in normal digestion and what sort of things to look out for when we're dealing with our patient examination. So as all examinations go, we always start with our subjective data. So what we absolutely need to ask is everything that will give us red flags. Okay, these questions here essentially will tell us the difference between something that is not too bad and will probably pass, all the way up to something that needs further investigation and probably medication as well. Okay, so with your patient history, you're going to ask about food intolerances. Okay, now I know it's a big flavour of the month. Okay, everybody's gluten intolerant and gluten's evil, dairy's evil. Food intolerances is a causative agent of diarrhea because of its associated inflammation. Now, every time we eat something, you will produce serotonin, gastrin, and histamines. So when you eat certain substances, those substances are going to result in an inflammatory response. That is normal digestion. Some people, if they haven't eaten a certain product for a while, like lactose, like gluten, and then all of a sudden eat those products again, they can have associated diarrhea. It does not necessarily mean that they're intolerant, it just means their body's not used to those foods, and therefore the inflammation they're not used to either. So they get the diarrhea. If someone has an intolerance and has ingested the food, it can be the cause, but don't fall back on that being the cause and finish your investigation from there. Just keep it in the back of your mind. Okay, so always ask about the food intolerance and then obviously what they've eaten. Now, medications that they're on, there are a lot of medications that slow down, increase, aid in digestive motility. Okay, medications that you wouldn't expect. Now, I'm not going to go through all the ones today because there are just too many. So if they're on medications, anything unique, okay, if you have time, look it up, see if it can have associated problems. Okay, I think everyone when they went to a school would always say an adverse side effects of medication is, I don't know, vomiting and diarrhea. Okay, so there's a reason for that. It plays a big role. Particular note is obviously look out for your antibiotics. Very common cause of diarrhea. If they have any comorbidities, always to keep those in the back of your mind. Now, travelling is a big one for your pathogen side of the house. Okay, if you go to a new area where your body has never been exposed to a certain pathogen that is found in that area, okay, it is more likely for you to contract that disorder because you don't have any antibodies for it. Okay, so it's a lot easier for that pathogen to actually attack you. So if they've travelled, make sure you have all the details of their recent travel in order to add it to your investigation. Other things to look out for is other problems associated with the diarrhea. As I mentioned before, diarrhea is not necessarily the diagnosis, but a causative agent of something. So we need to know things like nausea, vomiting. Do they have a fever? Is there any associated pain with this? Now, if you have a fever, which we'll talk about later, it generally bumps it up problems. If you have vomiting and diarrhea, then we're dealing with inflammation of the stomach, probably, and the intestines themselves. If you have associated pain, you are generally dealing with a problem of the small intestine. As I mentioned before, the actual inflammation and swelling, bloating of the small intestine can cause a lot of the discomfort associated with your abdominal pain. It is also, it can be indicative of certain pathogens as well. Okay, so if they have pain, do a proper PQRST investigation in order to find out what sort of pain it is. Whether it's cyclic, whether it's sharp, dull, all these sorts of things can tell us whether it's inflammatory based, muscular based, and pathogen related. So that's patient history. General, I know, but we still need to ask it. From there, we can look specifically at the diarrhea itself and things that will tell us whether it's more likely to be mundane or something we need to investigate. First one is timing. Now, all the textbooks give you a 14-day period to help diagnose the difference between acute or chronic diarrhea. So if anyone's had diarrhea for more than 14 days, yep, that's a flag. That needs investigation. Okay, but you can be a little bit more lenient with that one depending on how often they go. So if they've had loose stools, essentially, now what's graft? I know they say what's normal, what's not, but what has been graft is, normal is 3 times. Okay, so if they go more than 3 times, then that's considered abnormal. Now yes, we always take the patient's personal preferences, if you will, or bathroom habits into account, but general rule of thumb is more than 3 times is too often. Okay, because remember, diarrhea can just be loose stools. Normal bowel motions 3 times a day, but always loose. 14 days. It doesn't always have to be associated with the explosive. When you have a combination of long duration plus or minus frequency, then you have a problem. They're starting to look at diagnosing diarrhea now, not necessarily based on the consistency of it, but more so associated with the magnitude of output. Okay, quite interesting reads. If you're ever interested, they look at how much someone is going to a toilet as opposed to what the consistency is necessarily. Okay, so timings are important, very important. The next thing we need to look at is the colour and consistency of the actual feces themselves. Now, colour plays a huge role because it tells us a story of how long it's been in the digestive tract for, and if there's associated ancillary problems as well. So normal fecal colour, being brown, is only brown because of the presence of bilirubin, which is broken down red blood cells through the liver into the gallbladder, along the biliary duct, into the digestive system. So that is normal, that is brown. If you have the absence of bilirubin, or a muck up within the actual biliary tract, so a blockage within the bile ducts, then your feces are not going to be brown. So you can note 2 problems from that. If it's not brown, look for other signs of jaundice. If there's no other signs of jaundice, then you're probably dealing with the fact that the fecal matter haven't been in the digestive tract that long. So it isn't in there long enough in order to mix with the bilirubin in order to have the brown colour. Same true with consistency. If it is completely water, then it's either not staying in the large intestine long enough, or the large intestine is profoundly inflamed, which is slowing down the absorption rate. The consistency of the diarrhea, mixed with the timing, gives you an idea of how much or what sort of fluid resuscitation this person is going to need, which we'll get to later on. Okay, but all paints a picture. Now, for the bad stuff, blood and mucus present in the diarrhea. Now, frank blood, you're mostly dealing with the large intestine. Blood that is black, then plasma, probably small intestine, but not common. Okay, both presence of blood and mucus generally point to problems with the large intestine and things like ulcerative colitis, that sort of thing. So if there's any blood and mucus present, regardless of timing, colour and consistency, that is a flag. That needs investigation, no more questions. Okay, well no. Basically, it doesn't matter what else comes up, you're already going to pass them on for further investigation. Okay, and the last one to look at is looking at their disruption. So disruption of their life. If someone comes in and says, I have diarrhea, I've had it for 10 days, and then you get down disruption, they go, oh no, I've got complete control, just every time I go to the toilet, it's loose. It's probably something 10 days, it's getting close to being bad, but it's not as bad as saying, I no longer have a diet, I have anorexia, the diarrhea wakes me up during the middle of the night, and I have no control. I'm bolting to the toilet and often missing, finding that I have feces through my pants throughout the day because I'm leaking. Okay, that's more red flags than the other one. Okay, so disruption of life looks at person's appetite, whether or not diarrhea wakes them up during the sleep. It's not normal to need to go to the toilet to open your bowels whilst you're sleeping. Okay, it is a function that naturally shuts down whilst you're sleeping. So if it happens during the middle of the night, it means that you have an imbalance. That something is taking over normal function. Same too with control. If you lose control because it is that violent, then it's a red flag. It needs treatment and investigation. Okay, so that's the questions that we need to ask. From there, we need to look at a few things. Okay, we need to get some observations. Okay? It's not just about questioning. Questioning is fantastic, often poorly done and paid lip service to, but it's the actual questioning that can lead us down the right path to what sort of examinations we should do. So starting right at the top, you do all your obs. Okay, we know we always do obs, but this time you're not just taking obs because you think you have to, someone's looking over your shoulder. Now we're taking obs and we're starting to look at the actual obs to see if there's problems. So starting with the temperature. Doesn't really matter what way you take the temperature, okay, outside of the archaic of course, but you need to take a temperature and take note if someone with diarrhea is febrile. Okay? What that means is there's a connection with the problem and the actual circulatory system. So whether that connection is T cell, epithelial wall destruction, macrophage interaction, whatever it is, you need something like that in order for the pyrites to be released, in order to give the temperature. The only other explanation for temperature is the person is profoundly dehydrated, therefore has lost the medium of temperature control. Okay, and there's a very fine window between that because you often get the opposite effect if it goes on too long, okay, like cold shock and that sort of thing. Okay, so that's temperature. So take it, and if you have a temperature, it's another flag. Okay, it gives you the flag. Now respiratory rate can be another one. Now this one's not an absolute. Okay, it's not a guarantee, and there's no mean a diagnostic tool, but it's something to keep into account. When somebody has diarrhea, now mostly diarrhea and not vomiting, they will become acidotic. The reason they become acidotic is the actual secretions, so assuming the actual diarrhea is caused by osmolarity or secretions are made up of high bicarbonate solutions. Most of the bicarbonate within the body will be put into the digestive tract and lost during diarrhea. Okay. Now, loss of the bicarbonates is obviously losing that buffer for free hydrogen ions, which causes your acidosis, metabolic acidosis. Okay. We often have a mix-up of chloride and water being pushed in with the bicarbonates as well, which only aids in the actual acidosis as well. So an easy and early sign of compensation for acidosis is an increased rest rate. Okay, it's one of the first signs. Obviously, trying to blow off excess CO2 in order to compensate for the metabolic acidosis. It is also a nice and early sign for dehydration. So, particular one to take note of. Other one we need to look at is your blood sugar levels. Now, if somebody's eating and they're eating sugar, good chance they're going to be absorbing the glucose itself. Okay, so blood sugar level does not drop purely as a result of having diarrhea. Okay, if anything, it may get too high because of the dehydration. But if the person isn't eating for a long duration of time, then they can have a low blood sugar level. Okay, so just keep note of that. Outside of your OBS and links with them is we need to look at signs of dehydration, because that's obviously the big ticket item and the main problem associated with diarrhea is someone's dehydration. Loss of fluids, electrolytes is dehydration. So we look at the eyes, see how sunken they are, look for the presence of tears and moisture, look at their mouth and inside the mucosa for dryness. Skin turgors is quite difficult to look for, okay, usually far more effective with children, but look for it because when you see someone really dehydration over a long period of time, you will see skin turgor. And ask the person about their thirst. See if they are thirsty compared to, poor thirst, generally associated with, if they're really thirsty, mildly dehydration, severe dehydration, they often have a poor connection with whether or not they're thirsty or not. Okay, it sort of goes the other way. With that, we are very interested in their urinary output. Now, because in the environments we're in, we can't necessarily put a catheter in and monitor them for those periods of time to see how much. Patients aren't very reliable when they have diarrhea to ask them how many times they go to the toilet, because if it happens, it often happens with diarrhea, so it's forgotten. So if we do a urinalysis, then we can look at specific gravity, we can look at the pH of the urine, we can look for the presence of bilirubin, early signs of infections like nitrates. Okay, it's a very useful test to do. It can be done easily in a field environment, and it gives us an idea of the dehydration and the overall patient status. Okay. Other things we can look for is we can do our auscultation, percussion and palpation. Now if we are planning on palpating, then you must do your auscultation first, okay? Because any percussion and palpation of the digestive tract can increase peristaltic movement itself, and then obviously give you more problems, okay? Or give you a false positive when you're listening to it. Now, when you're listening auscultation, it's not easy, and it can take a period of time. And if you're not well practiced, it's difficult to know whether it's, you know, fast, slow, a problem, treacling. So, if you're insistent and you want to listen, then the best place to listen is the ileocecal valve. Okay, so that's where the small intestine meets the large intestine. So if there is increased peristaltic movement, you're going to hear it there first. You're going to hear the movement of the fluid from the tightened small intestine to the large intestine. Okay, so it's the most audible, and a lot of the time you'll actually hear the groaning of it as a result of that area itself. Okay, so if you're insistent on listening, then that's the best place to listen. Outside of that, when you're palpating, just be gentle, okay? If somebody is complaining of abdominal pain, when you're dealing with diarrhea, it's not common for palpation to increase the pain. Okay? So if it does increase the pain, or if you have Blumber's sign, okay, rebound tenderness, then you obviously need to start thinking about other associated organs and inflammation, okay? Because that's what those signs will tell you, is profound inflammation of a particular area on palpation. Okay, so we look for it, and that's a big warning sign, obviously, of your appendicitis, but not uniquely. Okay, from there, we need to decide whether or not the person needs pathology. Okay, now if you have any flags associated up, so it's no longer benign, it's now actually something that needs investigating. So anything that is tipped it over that moderate to severe thing, then a test should be done. Now, the test that can be done is obviously MCS, OCP, and PCRs. Now, yep, don't have to do all three. Okay, the difference is MCS is mostly associated with your bacteria. Okay, so that's checking out your actual cultures. Your OCP is looking for your parasites, so it's looking for ova, or it's actually looking for your helminths, skins. So as they grow, they leave particles behind, they leave eggs behind. Okay, and you can see them with the OCP. Now the PCR, polymer chain reaction, is looking for your viruses. Okay, viruses are one of the leading causes of pathogen-related diarrhea. Okay, far more common than any of the other two, believe it or not. So PCR, if you believe it's a virus, can be needed. Okay, if you want to track it down, especially if you're deciding whether or not to give this person antibiotics. Obviously not you, but further on. Okay, there's the tests that can be done. What about management? Everybody, every single person that has diarrhea should have education on hygiene. Okay? Diarrhea spreads, okay, if it's pathogen related, which is majority of the causes is associated with pathogen related diarrhea, viruses and then bacteria. Okay? So there that you need to teach them about hygiene. When you have watery stools, there's no escaping it. It will get on your hand. It absolutely will get on the patient's hands, and it will get on the patient's clothes, and will get every single where that patient has touched, and it will spread. Okay, there's no avoiding it. Now, patients should be encouraged to wash their hands with soap and water wherever possible. Okay, so then if there's any enveloped viruses, they can be taken care of by the actual soap and water. In the absence of soap and water, then religious ethanol hand wash needs to be done. Okay, not only that, but stop the patient from sharing anything, any food products, any eating utensils, any cigarettes, anything at all. Okay? If they're in a field environment and they cannot keep themselves clean and they have uncontrolled diarrhea, so they need to go to the toilet multiple times during the day with high water-based consistency, then you're best off getting rid of them. Okay? Even if they appear perfectly fine and not very dehydrated, their risk of spreading it to other people is high. So look at getting rid of them, especially for a training exercise. There's no reason keeping them in the field, really. No good reason. Okay, so everybody needs hygiene. Now hydration is important, very important. So oral rehydration salts were designed for diarrhea. Now they contain glucose and sodium chloride within the actual ORS, and they are designed to be absorbed in the presence of inflammation of the bowel. Okay, so within the small intestine and the large, you will have ion channels that essentially allow glucose, sodium and chloride to go through. And they're always open. They're not voltage gated or anything like that. They're always present. So just the mere presence of these solutions in the right osmolarity will cause them to be absorbed and take fluid into it. Most of fluid absorption that occurs in the large intestine in the absence of disorders is purely done through hydrostatic pressure. Increased hydrostatic pressure within the large intestine pushes it in between the epithelial cells of the large intestine. Great, perfect. If you have inflammation, okay, or a high motility, indicative by consistency, frequency, loss of control, then you are going to need oral rehydration salts. Now the World Health Organization informed me of a way for you to make your own ORS. Okay, so if you get a litre of water and you mix 2 to 3, now the literature's open, some say 4, some say 6 teaspoons of sugar, so 2 to 3 rat pack sugars, and half a satchel of rat pack salt, then you've essentially made yourself ORS, okay, in its litre consistency. So having said that, the recommendation for replacement of fluids is not very high. So anyone over 10 kilos, which is all of us, essentially needs, for anything that's mild to moderate dehydration, you need a replacement of 140 mils ORS solution after every bowel motion. Okay, so that's the recommendation. Okay, what a lot of these recommendations don't take into account is the level of dehydration the patient was in beforehand. So anybody working hard in a field environment, in the heat or the cold, is going to have a level of dehydration already. So sometimes the 200 ml recommended for the ORS isn't going to be enough. Okay, so if you think they need more, or you want to save the ORS, or you can't have a supply for everyone, then keep the formula of making your own ORS satchels for the patient in their litre water bottles for them to take away and drink. Okay, now with this, you very rarely need intravenous therapy. Okay, the only time we need to consider IV therapy is if the person cannot hold down fluids. Now, most of the time, if a person was to scull a large amount of fluids in the presence of gastroenteritis, they will vomit. That is normal. Now, most organisations out there recommend that after that, you give them 20 minutes, and then you still try oral for them to drink slowly, small amounts this time. It's not that intravenous therapies are essentially going to cause more harm to the patient, but it obviously has increased risk, and a lot of the literature is suggesting that outside of severe dehydration, it's not required. In the presence of severe dehydration, it absolutely is required. So we're talking 20 mils per kilogram of intravenous therapy is needed, and then a follow-up of 100 mils per kilo over 4 hours of oral fluids as well. So that's the recommendation for severe dehydration. Okay, so you look at your patient, make the judgment call. Just realise that ORS is specifically designed for diarrhea. Okay, it doesn't really offer that much benefit outside of diarrhea. So as a means of a sports drink or an energy booster or whatever like that, it's 200 mils. And putting one of those ORS satchels within a litre, it's not really giving you that much that you're not already getting from a normal diet and normal drinking. Now, pretty much every other drink that is designed is going to be subpar in the presence of diarrhea. So water itself won't be absorbed when you've got full inflammation of the large intestine. Okay, it won't be. You'll actually just make the diarrhea worse. Now, your high osmolarity drinks, like soft drinks, fruit juices, Powerades, whatever else there is out there, that high energy sports drink stuff, which is basically syrup when you mix it with a litre, most experts recommend it as written that that's going to increase someone's level of dehydration in this state, because it's going to encourage osmolarity based diarrhea. Okay, just remember, inflammation, you do not have the normal absorption rates that you would have in the absence of diarrhea. So diarrhea, stick to ORS, maybe consider intravenous therapy, okay, and go from there. Now, in regards to diet, a lot of literature, a lot of studies, a lot of talk has happened in regards to diet. So since the 60s, paediatricians have pretty much recommended what's known as the brat diet. I always thought that was adorable because they're paediatricians and they're dealing with the brat diet. Okay, but that's stands for bananas, rice, applesauce, and toast. Okay, so their theory was you'd eat this diet in order to give your digestive system a rest whilst it has this problem. Okay, so it has this problem, so you've got to give your digestive system a rest. Okay, so whilst a lot of diarrhea, especially associated with bacteria, remember I started, it's got to do with the macrophages and the introduction of more macrophages, increasing the actual secretions in order to remove the pathogen. Okay, that's where a lot of the theories have come from to let the diarrhea pass. Okay, so that's where this brat diet came in, was essentially to give the digestive system a rest. Now, there hasn't been anything proving that it actually works. There hasn't been anything proving that it does any harm. So if you yourself have done this for many years and it hasn't done any harm, then continue to do it. If somebody does not eat rice, okay, or has never had applesauce, or doesn't have toast because of the gluten product, or whatever it is, then the brat diet isn't going to work for them. They recommend these days is getting back to normal diet. Whatever they consider normal diet is the best thing for them. Okay? Now, when the dairy debate comes in, the main reason the dairy debate was ever a debate was because of the rotavirus. Now, the rotavirus, when you're dealing with diarrhea, is responsible for up to 40% of diarrhea cases. Okay, so it's pretty common. Now, when you are infected by a rotavirus, you have the inability to process lactose. So therefore, with a rotavirus on board, having dairy, you're not going to produce the lactose. The lactose is going to become a non-absorbable material, which means you're going to have secretory problems from the rotavirus, and then you're going to have an osmolarity problem from the lactose itself, okay, which will make your diarrhea worse. Okay? But outside of that, there's no proof that it does any harm. So if you normally eat dairy and you try and it doesn't make it worse, then fine. If it does, then obviously drop the lactose because you've probably got a rotavirus. Now it's not diagnostic, but that's just the writings. Okay? Now, in regards to medication, if you believe it's bad enough to get the actual pathology, then wait out until you get your ABs. Now, there's certain characteristics of diarrhea that are well known, like Giardia and Helmus and that sort of thing, so you'll know what those sort of ones will generally get the medications early. Okay, but if it's bacteria related and you want to give your antibiotics, or doctors want to give the antibiotics, then it's generally well backed up by the actual MCS itself, okay, to make sure it is bacteria, not a virus. Now, whilst there's some things that are obvious, like Shingales will have a high temperature all the time, as opposed to viruses, which will sometimes have it, it's still best just to get the screening in order to definitely know before you're giving your actual antibiotics. Now, should we give loperamide? And there's the question. Now, obviously, as I alluded to before, the theory that the body itself is producing increased secretions in order to remove the pathogen. Okay, so it is difficult. Now, there is cases of children that have typhoid. Okay, now typhoid being quite a very, very nasty one that spreads from the digestive systems to the ancillary organs through the entire body. Okay, so they were given loperamide and it ended up killing them. Okay, so there are cases of that, but essentially loperamide is available and it is recommended for use for acute diarrhea. All I'm going to recommend is if there's any red flags of increased severity or duration of the diarrhea, then I wouldn't give loperamide. If you are planning for further investigation, then I wouldn't give loperamide. If the person is moderate to severe dehydration, then I wouldn't give loperamide, because it generally means that there's bigger problems going on in their body, and loperamide essentially is designed to decrease peristaltic movement. Okay, that's what it does. Now, if your normal recovery process is increased peristaltic movement, then you're obviously going against it. So it is a difficult one, but that's generally the way I work. Is I give it to people with mild, controlled diarrhea. They have loose stools. Just like that, a little bit of support, they're well controlled, there's no other flags or anything that I've seen with them, it's just a mild case of diarrhea, then they get loperamide. Anything outside of that, they get additional management, okay? So that's that. Now obviously we could talk about antiemetics, but we're pretty much just focusing on diarrhea itself today. So look up your own versions of antiemetics, but a lot of them are quite obvious what not to give. Okay, so that is the first patient examination one on diarrhea. I hope you got something out of it. Until next time, take care.